I am so excited to have NEJM's Editorial Fellowship Program as a sponsor for this podcast. Hear from Dr. Aberna Pearl, an NEJM Editorial Fellow, on her experiences.
The working environment is so friendly to the point where a dog attends our editorial meeting, a dog named Scout, and he frequently comes to smell my lunch in my backpack and so on. So yeah, people like Eric Rubin, the editor-in-chief, are very personable and approachable. And I'm going to miss this year so much. I think anyone who's chosen for the role has a lot to look forward to. So if you're willing to learn and try something new, if you have a little bit of a creative streak perhaps, and you're interested in taking a step back and seeing medicine from a bird's eye perspective, I think that's all you really need.
And this is a 1-year, full-time paid editorial fellowship. Check out the show notes for the link and learn more about the program and the application.
Welcome to another episode of Beyond Journal Club, a collaboration between CoreIM and NEJM Group.
The goal of Beyond Journal Club is to take landmark clinical trials and put them into context, telling the story of how we got to where we are and what it means for how we take care of our patients. I'm Dr. Shreya Trivedi, an internist at BIDMC.
I'm Dr. Greg Katz, cardiologist at NYU.
I'm Dr. Chris Kodanidis, an editorial fellow at the New England Journal of Medicine.
And I'm Dr. Clem Lee, a former fellow and a current guest editor at the New England Journal of Medicine.
Today, we'll be discussing the REDUCE-AMI trial. This trial explored the role of beta blockers in patients with a recent heart attack.
This is one of those studies that makes me think of that old adage they tell you when you start med school. In 10 years, half of what you learn is going to be wrong. The problem is that we don't know now which half it is.
Yeah, it's so funny that we were all told that. And I'm so excited to get into this because for at least as long as I can remember, beta blockers have been considered the standard treatment after a heart attack.
Before we spoil any conclusions, first, we're going to talk about why beta blockers even make sense as a post-MI treatment in the first place.
Then we'll get into the story of beta blockers and how their indications might have evolved over time.
And finally, we'll take a deep dive into the REDUCE-AMI trial and think about whether some of the textbook ideas we learned about in medical school may have passed that clinical expiration date.
All right, so to kick off the story of beta blockers and MI, we first need to dive into how beta blockers work in the first place. Why do we think that beta blockers could even help with MIs to begin with?
Well, beta receptors are located all over the body, but we're going to focus our discussion today on the heart. So that means we'll stay cardioselective with beta-1 receptors, which are predominantly located on the myocardium.
So beta-1 receptors are responsive to changes in sympathetic and vagal tone. And so when these are stimulated with drugs like norepinephrine or epinephrine, heart rate goes up and contractility increases. And when you block them, like with the beta blocker, the heart rate slows down and the heart contracts with less force.
Yes. And so then after a heart attack, the thinking is that by decreasing the heart rate and contractility, you also lower the myocardial oxygen demand. And so in the situation where the myocardium isn't getting enough blood flow, like in a heart attack, beta blockers can help reduce damage to the heart.
Exactly, but beta blockers don't just decrease heart rate. They also reduce the risk of arrhythmias.
And as we're talking here, I think it's worth pointing out that there is a difference between treating somebody during an acute MI with a beta blocker, which has a lot of risk, versus treating somebody after an MI that's been revascularized. And so for the purposes of our discussion, we're really talking about treating patients after an MI when they've been treated and stabilized.
I look forward to that conversation, Greg. But for now, we've laid the foundation for beta blocker physiology, and so let's look at how these drugs went from theoretically beneficial to being the standard of care.
Okay, so the story with beta blockers in ischemic heart disease starts in the 1960s and 70s. Back then, we had some small studies that showed a reduction in mortality and reinfarction in patients who had an MI.
But those trials weren't big enough to fully change practice. Beta blockers fully rose to prominence after the landmark beta blocker heart attack trial, published in 1982 in JAMA.
And this trial is written out as BHAT, beta blockers and heart attack trial. And we went back and forth. Is it BOT? Is it BHAT? If anyone knows how to actually pronounce it, please email us. But for, I guess, the sake of the rest of this episode, we're just going to call it BHAT.
Yeah, I'm cool with that. So BHAT showed us that patients treated with propranolol after a heart attack were less likely to die than those treated with placebo.
And BHAT also had a really interesting study design. So the investigators here actually titrated up the dose of propranolol until they got to the serum level they wanted patients to achieve.
Testing serum levels and adjusting doses in 1982. This is the OG precision medicine paper.
Yeah, I know, right? And the results are kind of unimpeachable. Propranolol reduced mortality, cardiac death, and arrhythmic death compared to placebo.
So cool to see a trial take a theoretical mechanism of action of lowering oxygen demand, and that actually ends up predicting the results of better outcomes from beta blockers entirely.
So BHAT was a game changer and established beta blockers as the standard of care in ischemic heart disease after an MI. I mean, what's not to love? They reduce death, treat angina, reduce arrhythmias. And we can't forget how revolutionary this was at the time. When BHAT was published, we didn't have anything like the arsenal of heart attack treatments that we do today. No statins, no PCI, no P2Y12 inhibitors, even bypass surgery was just coming onto the scene. So at this point in time, if you had a heart attack, all you did was get put in the corner, take morphine, and try not to die.
Wow, gotta love the 80s.
Yeah, well, after BHAT, the momentum for beta blockers continued with a Capricorn trial, which stands for the very easy carvedilol post-infarct survival control in left ventricular dysfunction, which was published in 2001 in The Lancet.
Oof, that full trial name is a mouthful, so I'm glad they abbreviated it. Capricorn came on the heels of major heart failure trials showing the efficacy of beta blockers. So there was a lot of palpable excitement for beta blockers in general.
So Capricorn was different from BHAT in two ways. First, Capricorn looked at a sicker patient population post-MI who also had LV dysfunction. And two, these patients were on better medical therapy. They had ACE inhibitors. A lot of them went for PCI or received thrombolytics. These were just sicker patients who had better medical therapy when they were enrolled in this study.
Yeah. And what did Capricorn show? Capricorn showed a large mortality benefit in patients post-MI with a reduced ejection fraction. And that really cemented beta blockers as a mainstay treatment in patients with left ventricular systolic dysfunction post-MI.
One of the things that's really interesting about Capricorn is that there are a number of different plausible explanations for why carvedilol was so successful in this study. One is it's just a beta blocker, and beta blockers help in ischemic heart disease and systolic heart failure. And then the second hypothesis is maybe there's something special about carvedilol. Maybe it's the alpha blockade that has increased afterload reduction. Maybe it's the antioxidant effects, the metabolic effects where carvedilol tends to improve insulin sensitivity and other beta blockers tend to make it worse.
Yeah, so just to reiterate what we've talked about so far, Capricorn solidified beta blockers after an MI with a reduced ejection fraction. And so the standard of care was born.
Yes. And so where do we go from here? How do we get to the point where the beta blocker plot thickened enough for us to even question beta blockers, right? What was the setup for the Reduce AMI trial?
All right, so actually, Shreya, it took a while for that plot to thicken, decades even. It was so striking to me just how long that gap was between the major trials in this space. So if you look at BHAT, that was in 1982, and their protocol was almost like handwritten if you look at it. And then Capricorn, MERIT-HF, and CIPUS-2 were all published by 2001. And then there were no other big RCTs looking at beta blockers in patients post-MI until now, Reduce AMI.
But obviously, there was still some great stuff going on in the background. We had all these advances in lipid management, PCIs, antiplatelet therapy. There was this whole revolution in the way we take care of patients with diabetes and cardiovascular disease. So basically, the way we take care of stable ischemic heart disease completely changed in those couple of decades.
And over that time, the narrative on beta blockers for ischemic heart disease just started changing a little bit. There were a handful of important observational papers that started looking at the role of beta blockers in patients who had stable ischemic heart disease but didn't have systolic heart failure and really started questioning whether they truly had a benefit.
That's right, Greg. It was interesting to me to dig into the evidence here, and I realized a pattern started to emerge. A lot of these observational studies suggested an upfront benefit of beta blockers in the first 30 days to a year, but after that, the benefit really seemed to subside.
Yeah, and to speak to that point a little bit more, there was a 2015 meta-analysis involving over 40,000 patients that showed beta blockers did improve the survival overall, but in the subgroup analysis, its benefit waned after 1 year of beta blocker therapy and didn't show a survival benefit in patients with a preserved ejection fraction. So that evidence started to call into question, hey, is there a benefit in patients with preserved ejection fraction? And how long should we keep patients on beta blockers post-MI?
And then in 2016, the FAST-MI registry study showed a very similar pattern, that early beta blocker therapy was associated with reduced short-term mortality, but not reduced 1-year mortality.
And it was just meta-analysis after meta-analysis, including one that had over 100,000 patients that continued to suggest little to no benefit of beta blockers in patients post-MI who didn't have heart failure. And some of the registry data even called into question whether there was a short-term benefit of that first year of beta blockers post-MI.
Ah, man, this is getting super juicy. No benefit at all? Wow.
I know, right? It's a big contrast to the earlier decades, isn't it? And by the end of the 2010s, clinical guidelines had begun to reflect this uncertainty.
Yeah. So the body of evidence really brought us to this important question. Do beta blockers still belong among the contemporary therapies for ischemic heart disease?
And all of this data, which even includes a Cochrane review on the topic in 2021, really made the compelling case that another trial seemed worth doing. But this is medical dogma. This is what everybody was doing. And so we need to give the investigators who were asking the question about beta blockers post-MI a ton of credit. To question something that is so ingrained in what we do takes a lot of courage. I mean, prescribing beta blockers post-MI is this important quality metric that impacts hospital ratings and even physician reimbursement.
No, I had no idea.
I used to get a report card about how many of my post-MI patients were being prescribed beta blockers.
That is humbling.
Well, and all that brings us to Reduce AMI, the first randomized controlled trial in the space of beta blockers in a quarter century. The Reduce AMI trial, published in the New England Journal of Medicine in April of 2024, was an open-label, randomized controlled trial. It was conducted across 45 centers in Sweden, Estonia, and New Zealand.
And REDUCE stands for Randomized Evaluation of Decreased Usage of Beta Blockers, with the C and the E coming from the middle of the word beta blocker. Greg, I don't know if this is my favorite cardiology trial acronym.
On behalf of all of cardiology, we politely request you stop micromanaging our acronyms. But looking at these patients, their median age was 65 years old, 80% of them were men, about half had hypertension, and 1 out of 8 had a history of diabetes. Patients couldn't be enrolled after STEMI or NSTEMI, and every single one went for coronary angiography and had obstructive coronary artery disease.
And the investigators wanted to ask the question whether beta blocker therapy was beneficial for patients who had an acute MI and whose ejection fraction was 50% or greater.
And just to say it out loud, the reason why patients with a reduced ejection fraction were not included is because we know that there is a clear mortality benefit in treating systolic dysfunction with beta blockers.
That restriction narrows down the patient population they were studying, and the trial enrolled about 5,000 patients.
Okay, not to sound ungrateful here, but I'm surprised that a cardiology trial only included 5,000 patients. I'm so used to having cardiology trials that have twice that number. I'm guessing some fancy stats were done and the sample size calculation said, okay, this was enough statistical power in this post-MI population, but still a little bit surprising.
5,000 patients is kind of impressive. There's just a lot of shade from the non-cardiologists today. If this were a lupus trial, there'd be like 50 patients and it would be a front page study.
Cardiologists set the standard so high, right?
It's not my fault that we spoil you with our evidence. And so the patients here were randomly assigned to one of two groups. One group received beta blockers, specifically metoprolol or bisoprolol, and the other group received no beta blocker therapy, but they weren't given a placebo. Treating physicians were encouraged to aim for a specific daily dose of about 100 milligrams of metoprolol succinate or 5 milligrams of bisoprolol.
Why did they not use carvedilol? I mean, carvedilol had this big deal after Capricorn.
So yeah, Reduce AMI used beta-1 selective blockers, specifically metoprolol and bisoprolol, for two reasons. First, these drugs are the most widely used ones in coronary artery disease. And also, practically speaking, metoprolol and bisoprolol were just the commonly prescribed drugs in the countries involved in the trial.
Okay.
And I do want to point out a few major differences between this trial and some of the other trials we've covered on this podcast. First, this trial was open label, which means that patients and doctors both knew what they were getting. And second, there was no placebo group.
And so those methodologic factors are really important. But when the outcomes in the study are new MI, which aren't really subject to bias or the placebo effect, I really worry less about the lack of blinding or placebo control.
Yeah, that's fair. They also did something unique for the patients that we should point out. For the patients who were on a beta blocker before enrollment, their beta blocker was tapered and stopped. They were assigned to the no beta blocker group.
All right. Now, with all that groundwork on this trial, Chris, do you want to do the honors of telling us what the results were?
Sure. Do I get a drum roll?
We can make it. You are the drum roll, Chris.
Well, the results were, in a word, neutral. So after a median of 3.5 years, the primary endpoint of death from any cause or a new myocardial infarction occurred in 7.9% of the patients in the beta blocker group and 8.3% of patients in the non-beta blocker group.
Okay, surprising. All right, so are we saying now that those hospital quality metrics need to be changed?
That is not what we are telling you. That is what Reduce AMI is telling you.
Yeah, and to break down the composite primary endpoint more, incidence of death, myocardial infarctions, neutral. And when we look at secondary endpoints, death from cardiovascular causes, also neutral. Hospitalization for AFib, neutral. Hospitalization for heart failure, also neutral. So in the end, all of those numbers come out as totally neutral.
So you would think that there'd be something in that composite for us to chew on, but there was nothing. And this is really provocative. This neutrality was across the board and continued even to secondary outcomes where I was pretty sure beta blockers were going to have an effect, like hospitalization for AFib or hospitalization for heart failure.
Yeah, that's crazy. Beta blockers we know to be important in helping with arrhythmia. So it's, very surprising to hear. So sounds like no benefit for beta blockers with those secondary efficacy endpoints too. How about safety endpoints? I mean, beta blockers are so notorious for side effects.
Yeah, totally. But the beta blockers were safe in this study, even if they weren't efficacious. There was no difference in heart block, hypotension, syncope, or new pacemaker implantations between the two groups. There was also no difference in hospitalizations for asthma or COPD, which is relevant here since beta blockers also block beta-2 receptors on bronchial smooth muscles.
And the neutrality here even extends to the subgroup analysis. And not to be a broken record, but for almost all studies, subgroup analyses are hypothesis generating, not hypothesis testing. But there was no signal that any particular group had benefit or harm from beta blocker treatment.
It wouldn't be a Beyond Journal Club if we didn't have Greg saying hypothesis generating, not hypothesis testing.
Okay, well, to summarize, Reduce AMI showed no benefit on survival or heart attack risk with beta blocker therapy in patients who are post-MI and have no LV systolic dysfunction.
This is a wild result, and it is so different than what we were taught in med school and what we're being judged on with these quality metrics, and frankly, what I've been teaching my residents for God knows how many years.
I'm sure your residents still think you're a great teacher. But how sure are we about these results? You all know by now that I'm a huge cynic with a capital C.
I am so excited to have Echo Core 500 digital stethoscope as a sponsor. I actually learned about them accidentally a year or so ago when I'd forgotten my stethoscope and my resident let me borrow his, and I just was like, wow, I've never heard heart sounds or lung sounds this clearly. You just get this extra level of confidence for those moments where you're asking, was that faint crackles? Was that an S3 gallop? And so that's because Echo's digital stethoscope amplifies sounds 40x, and then on top of that, it has noise cancellation so you can really hear with precision in a noisy ED or with a really loud roommate or other environments. Echo AI is also built in and helps you detect murmurs and AFib earlier. A cool thing also is that you can record that heart sound that you heard, share it later with your team, or on a case presentation. And then you can really trust the diagnostic accuracy. It's backed by 4 million heart sounds and 8 FDA clearances for the devices and the AI algorithms. So those who use Echo are twice as likely to catch heart disease. What I think is neat is that Echo 500 isn't just the digital stethoscope. You can actually also get an EKG tracing right on the app when you place an Echo 500 on a patient's chest. So no more waiting around trying to trace down the EKG machine on the floor. I trust Echo so much that I work with a team to create a special offer just for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/corium. Your purchase will be HSA and FSA eligible and may also qualify for CME reimbursement. Plus, Echo guarantees you're going to detect heart and lung sounds more confidently, and if you don't, you can return it with a full refund. Go to echohealth.com/corium for $50 off plus a free chest cover. That's ekohealth.com/corium. And with that, let's get back into the episode. Here at Corium, we're talking about the real things that can help anyone who works in healthcare. And today we're talking about how the scrubs you wear, they can make a difference. I remember the first time I saw one of my colleagues walking into a sign-out room looking way more put together after a night shift. And I knew right then and there, they were wearing FIGS. FIGS Scrubs is made specifically for us, doctors, residents, students, healthcare professionals who are putting in long hours and really need gear that can keep up and perform on our level. We have so much going on in any shift, right? Scrubs are the last thing we want to be thinking about. And that's why FIGS is great in that they're lightweight, stretchy, breathable. They have all the small touches that have made me a true convert. They're clean, they're modern, super functional, tons of pockets that I love for all the snacks, zippers that don't snag. and antimicrobial fabric to stay healthy while working. You deserve better scrubs. You deserve figs. So head over to figs.com and enter FigsRx at the checkout for 15% off your first purchase. That's figs.com, promo code FigsRx for 15% off your first purchase. And with that, let's head back to the episode.
Okay, so in terms of how sure we are about the results, Clem, on the surface, we have a neutral trial here, but when you dig deeper, there was actually a lot of crossover.
And to bring that point home, about 1 in 5 patients in the beta blocker group stopped taking the medication, and about 1 in 7 assigned to the no beta blocker group started beta blockers.
That's a ton, but I guess that does mimic real life, right? Some patients don't tolerate the medicine. Some patients need to start a new medicine after the initial treatment plan was decided on.
Yeah, in reality, that is absolutely true. But that crossover means that 20% of one group crossed over and 14% of the other group crossed over, and the primary outcome occurred 8% of the time. And those numbers leave me with a lot more uncertainty about what the right conclusions are to draw.
Yeah, and also remember that Reduce AMI was designed as an intention to treat trial. In intention to treat trials, patients are analyzed based on original assignments, so high crossover rates could potentially dilute the treatment effect.
And even with every single one of these caveats, which are all important, this is still a vitally important trial that is going to change my practice. When I am looking at the results of Reduce AMI, I keep coming back to the fact that this is just not that sick a group of patients. I know this is a group of people that just had an MI, and for patients, that is a life-altering event. But from a cardiology perspective, they weren't all that high risk. They had a normal ejection fraction, successful revascularization, average age of 65. Very few of them had diabetes. And so this is a group of patients who, by any sort of risk evaluation, you'd expect to do really well. So I'm interpreting the trial with this caveat. Patients who aren't that sick and the addition of beta blockers isn't going to move the needle for a group of people who you're expecting to do well regardless.
I think that's a super important point and really reinforces that we need to look at a population carefully when we're examining a trial. And older trials like Capricorn involve patients who were sicker with larger MIs and more severe left ventricular dysfunction.
Okay, guys, I feel like we've been talking about older trials a lot here, right? Maybe it's worth shifting our focus to newer studies. The one that caught my eye and I think is worth contrasting with Reduce AMI is ABYSS, which was a beta blocker withdrawal study that was also published in NEJM around the same time.
And as the acronym guru, I will tell you that ABYSS stands for Assessment of Beta Blocker Interruption After Uncomplicated Myocardial Infarction on Safety and Symptomatic Cardiac Events Requiring Hospitalization. Whew. Like Reduce, the trial acronym borrowed a letter from the middle of the word. The Y is from the Y in myocardial infarction. I guess you could say that the Y came from the middle of the abyss.
Okay.
Your life much calmer and easier if you just did not devote any brain space to cardiology trial acronyms. But ABYSS tested a different strategy than Reduce. This trial took beta blockers away from patients with stable ischemic heart disease and no recent MI who had been on them for a median of about 3 years.
And ABYSS studied a slightly sicker group of patients, including ejection fractions as low as 40%, not 50%. And what did they find? They actually found that withdrawing beta blockers increased hospitalizations.
Wait a minute, with everything we've been discussing, first saying that beta blockers after a heart attack is what we should be doing, and then a meta-analysis saying we don't need it forever, and then ABYSS suggesting that taking away beta blockers might actually increase hospitalizations. So does that mean we should just throw away Reduce AMI? It was a small study, 5,000 patients. I have so many questions here.
Withdrawing a drug that's stably in use is just different than starting something new. And so these are 2 different trials looking at 2 different questions in 2 different patient populations, and comparing them is comparing apples to oranges.
That's right, Greg. And I don't think the results from ABYSS necessarily contradict the results from Reduce AMI. ABYSS patients had lower EFs, and we know that beta blockers have benefit in this population.
And what I think we need to take away from these 2 trials is that understanding who the patient is matters a ton when you're considering the risks and benefits of different treatment strategies. The sicker somebody is, the more aggressive it probably makes sense to be with their medical therapies. And when patients aren't as sick, one of our jobs is to make sure that we don't make things worse for them by over-medicalizing their treatments.
Yeah, totally. Agree. And the other take-home point that I have is that clinical dogma really needs to be in question as the rest of standard of care evolves. Like, what should we clinicians be doing now?
Yeah, I think for me, my takeaway is that we shouldn't reflexively prescribe a beta blocker to every patient after a heart attack. And I think for patients who have preserved ejection fraction, who don't have any other indication for a beta blocker, like they don't have to be on a beta blocker for rate control and AFib or angina, it seems like the benefit of beta blocker is less clear.
Yeah, this is a huge shift in how we think about beta blockers. I liked how the editorialist Dr. Jernberg put it, and by the way, he's the PI of Reduce AMI, that beta blockers are, quote, approaching retirement. I just thought that was like an elegant way of describing something that had a good run, but we might think about phasing out, at least for a subset of patients.
Yeah, a big retirement party.
I'm also going to add one additional cynical take, which is that this is another case of Goodhart's Law rearing its head again about the concept of paying for quality in medicine. Goodhart's Law comes from economics, and it says that when a measure becomes a target, it ceases to be a good measure. And this is applicable because of the way that beta blocker prescriptions post-MI are considered an important quality metric for hospitals and for doctors. Maybe that was the case in a prior era, but I think it's really hard to make an argument that we should be incentivizing doctors through rankings to prescribe something with a questionable benefit in the modern age. And if our quality guidelines and our quality metrics do not evolve as quickly as the evidence base does, we have this gigantic metricized problem on our hands.
But also, we all know how much cardiologists love doing trials. This will not be the last word on the topic. We have ongoing trials like Smart Decision, BET-AMI, and Unblog that are pretty much asking very similar questions and are projected to recruit even more patients.
And I'm really looking forward to dissecting those trials and probably less looking forward to hearing Clem's critiques about their acronyms.
Hey.
I bet there's a lot of like cardiology bound people who are just like thinking about acronyms all the time. But yes, the story will continue to evolve.
And something that we've said on this podcast before is that you shouldn't let one single trial completely sway your practice unless you are more gullible than you should be. And so we have all of these smart investigators around to thank that they asked this important question about beta blockers post-MI. And pretty soon, we're going to have a lot more data, so we're going to be able to make decisions for our patients with an even greater degree of precision.
Yeah, and change quality guidelines, maybe.
Hopefully.
And then before we wrap up, a little behind the scenes, we went back and forth about a story that Greg shared with us in one of our sessions. It was actually after the Reduce AMI trial had come out, and this outcome for this patient kept him up at night, and he's thought about it over 100 times. And my vote was like, yes, let's have it on air. For me, it really hammered home some of the gaps when you try to translate the evidence to the patient in front of you. So stay tuned after the quick credits if you want to hear the story. I think it will certainly give even more food for thought to this topic.
And with that, we wrap up this episode. If you got any value from this podcast, our ask is that you share it with at least one other colleague who might also find this helpful.
Thank you to our peer reviewer, Dr. Jane Leopold. Thank you to Dr. Jimin Wong for the accompanying graphics.
And if you have any feedback or suggestions, please email us at hello@coreimpodcast.com. Opinions expressed are our own and don't represent affiliated institutions.
All right. So I took care of a 62-year-old man pretty recently. He didn't have much medical history, and he came in with an anterior wall MI. His troponin peak was around 150,000. He didn't present immediately after his pain, but he got to the cath lab quickly. He was completely revascularized. Post-PCI, he had a normal ejection fraction. He had apical hypokinesis, and it was clear he had apical hypokinesis on his echo. Our team talked about a beta blocker. One of my residents actually quoted Reduce AMI, and we looked at the paper. We decided against prescribing. He didn't have heart failure. His ejection fraction was normal. He was feeling well. He was completely revascularized. We held off. So he was discharged on dual antiplatelet therapy, but no beta blocker. I saw him for follow-up a few weeks later. He was doing really well. We got an echo because he was feeling a little bit weird. His ejection fraction had dropped to 35%. There was an LV apical thrombus. And I kept thinking to myself, I just should have prescribed that damn beta blocker. You know, his ejection fraction was normal, but he did have clear apical hypokinesis. He had a really high troponin. He didn't present instantly after his chest pain from all of those neurohormonal cascades that we talk about all the time as being maladaptive post-heart attack. And he still has not met the primary endpoint for Reduce AMI. He's a neutral outcome. He's not dead. He hasn't had a new heart attack. But he's not doing as well as we'd like him to be doing. And this gets to the crux of this question. Was he truly a Reduce AMI patient? And I think the answer to that is that he wasn't entirely. He had clear wall motion abnormalities and a pretty high troponin. There was a fair amount of myocardial damage. And I've thought about this case over 100 times since I took care of him. And I think about it every time we follow up or we do a video visit. Maybe we would have changed his outcome if we had put a beta blocker on right at the start, because we would have disrupted those neurohormonal cascades that might have led to a drop in his ejection fraction. And so when we talk about a trial like this and we talk about it as neutral, I want to be really careful that we don't just throw out the baby with the bathwater. it makes me concerned about these messages. And things are always more nuanced in real life than they are in paper when we're just talking about the top line outcome or reading the abstract of a trial.
Yeah. Or like for me, I think it makes me think a lot about like really looking into that table one. On surface, you're like, yeah, this guy was otherwise healthy, didn't have medical problems, 62, kind of really did fit the patient population, but there's more to the patient story than their demographic.
And if I had been his doctor before Reduce AMI came out, would I have consented for him to be randomized, or would I have just put him on a beta blocker and it's his ability to be randomized because clinical judgment says that he should be on metoprolol or carvedilol? I honestly don't know the answer to that question, but I certainly question my decision quite a bit, and I think about this case quite often.
Well, thank you so much for sharing. It certainly gave me food for thought, and I think it'll give the listeners also. All right. And with that, that's a wrap.
Second wrap.
You just realized your business needed to hire someone yesterday. How can you find amazing candidates fast? Easy. Just use Indeed. Stop struggling to get your job post seen on other job sites. With Indeed sponsored jobs, your post jumps to the top of the page for your relevant candidates, so you can reach the people you want faster. According to Indeed data, sponsored jobs posted directly on Indeed have 45% more applications than non-sponsored jobs. Don't wait any longer. Speed up your hiring right now with Indeed. And listeners of this show will get a $75 sponsored job credit to get your jobs more visibility at Indeed.com/kidsandfamily. Just go to Indeed.com/kidsandfamily right now and support our show by saying you heard about Indeed on this podcast. Terms and conditions apply. Hiring? Indeed is all you need.
If you're a podcast host, listen up, this one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle, and I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.